Namaskaram and good morning, everybody. Anything?
Good morning, everybody. It's wonderful to have a good number of nephrologists and other dignitaries today on a Sunday morning here. And without wasting time, I think we are a little behind schedule. We'll go to the next topic. That's actually, we all know that MHC is a group of genes that encode for a variety of cell surface markers, antigen-presenting molecules, and proteins involved in immune function. These genes are responsible for rejection in tissue grafts between unmatched individuals. And furthermore, the other importance of the HLA compatibility is that it will identify transplant candidates who are at higher immunological risk and who may benefit from more aggressive immunosuppression and very intense post-transplant monitoring of these individuals. So without wasting time, I invite Dr. Ankit Mathur. And as he was introduced, he is the Additional Medical Director of Transfusion Medicine and Transplant Immunology at Rotary TTK Blood Center, Bangalore Medical Services Trust. Over to you, sir.
Thank you so much, sir. After Siddharth's talk about the theory about HLA and polymorphism, I would like to decode how this theory information comes into the practical information, our day-to-day role in HLA lab. So I'll be talking something about various HLA antibody tests, and which includes the cross matches. Little bit about the new concept. He already introduced little bit about epitope matching, non-HLA antibody test, and something about HLA typing, especially high resolution HLA typing. These are the topics I would like to cover today. So we all understand 40-50 years ago when we started doing CDC cross-match, from in last so many years we have come to the level where we do epitope matching and high resolution HLA typing, and day by day the whole HLA, the protocols are becoming complex and complex and complex. We're still not sure whether this complexity in our testing finally helping the patient or not, but we believe that we are able to improve the graft survival in our patients. So these are the number of tests which you see in any of the HLA lab, starting from CDC cross-match, flow cross-match, Luminex-based lysate cross-match. These are the 3 cross-matches. 3 antibody tests which we offer in all the HLA labs. One is called antibody screen, one is PRA, panel reactive antibody test in form of percentage, single antigen bead assay. And the 2 newly introduced tests, which is one is complement fixing test, another one is non-HLA antibody test. And the second category of test is HLA typing, which is the HLA matching ABDR or high resolution or low resolution. So these are the tests which any of the lab will offer. Though the list looks longer, we cannot do all the tests for every patient. But it's good to find out which test is suitable for any transplant program, and with the help of this understanding, how to make an algorithm, how to make a protocol which is suitable for our own transplant. Of course, we need to see the finance available, the cost effectivity, and so on. But for our understanding, these are the tests available in our lab. There are 2 sets of antibody tests. One is called the cross matches, one is called antibody screen or identification kind of test. For cross match, we have to have a donor available, so we mix the donor and the patient, the sample, and find out whether there is any donor specific antibody present or not. An antibody, and only antibody tests, we really do not need any donor. We are just to find out whether patient has developed any HLA antibody or not. This might be applicable for a patient who is waiting for cadaver transplant, who is waiting for, or maybe had come from all the way from somewhere else and then just waiting for the transplant. Or maybe we want to select this patient for a paired kidney transplant program or for the virtual cross match. So this is how this antibody information helps us. Like I said, we need the patient serum for any cross match, and we need the donor cell to perform the cross match. The donor sample will be basically from peripheral blood. It could be from spleen or lymph node. It's in case of cadaver transplant. So in CDC cross match, we mix together and see the complement mediated cell lysis, and on the basis of cell lysis, we give a percent of cell lysis, and we say whether the cross match is positive or not. This is a very good cross match. Is a truly functional assay, truly functional cross match. But the problem with this technique is very, very less sensitive. So over a period of time, we have realized because of the low sensitivity, we are missing the information where the patient is having donor specific antibody, but we are unable to find out with the help of only CDC cross match. So therefore, most of the labs which are started doing some other methods along with the CDC cross match, this is absolutely nowadays considered not appropriate to go ahead with the transplant with the only CDC cross match because it's very low sensitive. So another cross match which is very commonly done in all the HLA labs nowadays is flow cytometric cross match, flow cytometry based cross match. Anil sir will be talking in detail about flow cross match, whether we have a T and B cell serological separation, and see whether the T cell and B cell both are coming positive or only B cell coming positive, and so on. So if both T and B cell are negative, we say cross match is negative. If both are positive, we say cross match is positive, and patient needs some sort of, means patient is having some donor specific antibody. And if only B cell is positive, means patient is having class 2 antibodies. This is how we interpreted the flow cross match. And as I mentioned, this sensitivity of flow cross match is much higher than CDC cross match. So it is advised to do CDC and the flow cross match together to find out the better information for the transplant. Next cross match, which is especially particularly India or some the cost the finance resource limited countries, it's common, which is called lysate cross match, or we commonly call it DSA cross match, in which we prepare a lysate from the donor sample mixed with the patient specimen, and we have the beads given by the manufacturer, and on the basis of beads, the donor lysate will go and bind, and the lysate will be prepared. And with the help of this, when we add the antibody, means the patient serum, we will come to know whether there is cross matches positive or not. So this is also a more sensitive cross match rather than doing a DSA cross match. It will tell us whether antibody is class 1 or class 2 positive. And another advantage which sometimes we see, the lysate what is prepared can be stored for a long time, and at least for 5 years. And for retrospective, when case of cadaver transplant, we can take out the lysate and do the cross match again. So it's a faster, it's a labor, not so much of manpower required for this cross match. So these are the 3 cross matches which we do in any HLA lab. Coming to the next set of the tests, which are only antibody test. In only antibody test, we have 3 commonly used tests. One is called screen. A screen is a very simple test where you have a patient sample and find out with the help of commercial beads, which we say, okay, patient is having any HLA antibody present or not. So these beads are the mix of many HLA alleles. So with the help of this with this test, we will come to know whether the patient is having any HLA antibody present or not in class 1 and in class 2. So there are various pools given by the manufacturer. So if any of the pool is positive, then say okay, antibody is present. But yes, we will come to know patient is having antibody present or not, but we don't know which antibody, and this antibody has what MFI value, and whether this antibody is donor specific or not. So this is about antibody screen. And second test, which is called PRA, or the percent PRA score. So we do, again we have the panel of beads provided by the commercial kits, and when we run these beads on the panel, we will come to know, okay, what is the percentage of the immunization, what's the score of immunization or the extent of immunization in the patient. If the percentage of the PR is very high, say 80%, 90%, we believe the patient is highly sensitized. So if patient might need desensitization or be difficulty in the getting a suitable donor for this patient. If the PRA score is low, say 10%, 20%, we believe the patient is not really highly immunized. So this helps us in the giving a percentage and finding out whether my patient is highly immunized or highly sensitized or not. So the second antibody test which we commonly do in HL labs, unfortunately the panels which we get from the commercial, they do not clearly represent about Indian population. And second limitation is we have most of our transplant programs are living donor transplant program. We have only 1 or 2 donors given by the family, and whatever we do, we have to deal with this donor. We don't have a great cadaver transplant program or great paired kidney exchange program where we can select the donor. So this has a very limited use in our transplant program. Third and the last antibody test, which is called single antigen, the bead assay. In this test gives us as extent whatever antibody patient has developed and what's the MFI value. And nowadays we consider this test as a gold standard test to select the donor, to do any monitoring in the transplant and so on. So one side we have all the alleles of the basic clinically significant antigens provided by the manufacturer, and then we run this panel on the patient sample. On this panel we will come to know what all the antibodies patient has developed and what is the MFI value. So with the help of these two information, we can select the donor, we can monitor the transplant, we can do the desensitization and so on. So this information look like this. So we have the alleles or the antigens on one side, which is positive, which is negative, and the MFI value. So this information helps us in identify which are the unacceptable antigens. Means unacceptable antigen means which I should not be in the donor. So I do not want a donor who will have this A2 antigen. So if the patient is having A2 antibody with high MFI value. And we perform virtual cross-match nowadays for many transplants now. And if we have a liberty of selecting a donor from cadaver transplant or a paired kidney program, this will help in sensitized patients and so on. And organ allocation, many disease donor program allocate organ on the basis of virtual cross-match. And of course, risk assessment, desensitization and the monitoring of your antibody removal, plasmapheresis and so on. This single antigen test information or doing a virtual cross-match really helps us. What's the benefit of virtual cross-match, which we talk a lot of time in most of the transplant settings nowadays. So in HLA virtual cross-match, one side we have a patient single antigen report available, which will have information of all the antibodies patient has developed, and another side we have a donor's high resolution HLA typing. We believe high resolution HLA typing available, and we see which antibody is donor specific. So with the help of this analysis, we select the donor or we choose the treatment for this patient. Of course, this virtual cross-match is very helpful in selecting as well as in the management of the transplant, but it has its own some limitations. So we have to have a patient single antigen test report which is as latest as possible available. It's not possible to do all the patient SAB test very often, so we have to be limit once in a quarter, once in 6 months and so on. And sometime it could be false negative and sometime it could be false positives because of either some prozone phenomena or because of some cryptic antigen exposure. This could be false positive. The single antigen report itself could be false positive, which falsely we will interpret this virtual cross-match as well. And we also know after CMC Velour's some study, we also know some of the Indian alleles which are not represented by by the commercial panels. So we'll never be able to know about status of these antibodies. These are the two common reasons we should be very careful in interpreting any virtual cross-match report. So after this antibody, a little bit about HLA typing. We all do the HLA typing for the matching of the donor and patient, how good or bad the match is. And of course, the legal requirement to have the relationship establishment. We use this method, so on. There are the various techniques which are done, which are used for HLA typing. Most of the techniques are low resolution HLA typing, which are still in commonly used, but nowadays many times we use high resolution HLA typing technique, and the common technique is next generation sequencing. Traditionally, we used to depend only on ABDR HLA typing, but we have over a period of time we have realized this information is not enough. Many times we see our graft are failure or allografts are going because of DQ antibodies. If we do not have DQ antibodies in matching, we will never be able to know whether this is antibodies DQ or not. C and DP still we are not very sure whether they are still clinically relevant or not, but still typing we believe it could be done for ABC and DP, DQ, DR. So as Siddharth just now mentioned about this is the HLA, the typing which is look like. So if high resolution typing means if you have minimum 4-digit information or the 2-field information, which is called high resolution HLA typing. But if you have only 1 field or 2-digit information, say in this particular case, if the typing report says 824, means it is low resolution HLA typing. But if my typing information says A2402, which is a specific allele present in my patient or in my donor, which is minimum high resolution HLA typing required. So for high resolution HLA typing, as I mentioned earlier, it's very commonly used nowadays. Before 5, 6 or 10 years ago, we hardly used to do high resolution HLA typing for solid organ transplant. But for the virtual cross match, when we have single antigen test reporting in form of high resolution, it is good, or it's required to do high resolution HLA typing also. So in virtual cross match, this information definitely helps us. And if we repository of the sample, the data, all these things will help. And of course, when Siddharth mentioned, if we have high resolution, then only we will be able to do some sort of HLA matching. I will briefly touch that also. So the single antigen antibody reports come in 4-digit. So we should have our antibody antigen information, the typing information also in 4-digit. Then only we will be clearly find out whether it is antibodies are donor specific or not. So correct assessment of donor specific antibody will happen if we have high resolution HLA typing available. And like I mentioned, next generation sequencing is the common tool or the common platform which is now done for HLA typing. I'm rushing, my time is only 3 more minutes now. So these are the various machines used for the next generation sequencing. In our lab, we use MiniSeq. In any sequencing, what happens, we have the donor on the patient, the sample, and we extract the DNA. We only particular target, which is HLA related, the portion of DNA, we find out and do a sequencing in the platform. And this sequencing is nucleotide sequencing, A, T, C, G, and so on. This sequencing will be matched with the IMGT database, and this database, with the help of software and our servers, we will finally define which genotype is for A, B, and C is of donor and patient. And this is how the information comes from the system, and this is how the reports look like with the minimum 4-digit or 6-digit typing information in form of reports. Little bit about non-HLA antibodies. Over a period of time, we have realized our grafts are failing, or grafts are going not only because of HLA antibodies. We see sometimes single antigen test is negative, no donor specific antibody, still we have a clear proof of ABMR. So we have realized there are some non-HLA antibodies in form of MIC-A, B, endothelin, myosin, and so on. These antibodies can cause the graft failure of or graft rejection. Not always we have to look for non-HLA antibodies, but whenever we have a clear indication of ABMR and our SAB is becoming negative, it is required to do test for non-HLA antibody and find out whether these are the cause or not. As of now, no recommendation or algorithm says we have to include non-HLA antibodies in our pre-transplant testing algorithm, or it should be included, yes. Uh, Coming to the epitope analysis, this as Siddharth just now mentioned, and we will be discussing in detail again, there are two basic applications for the epitope matching nowadays. What we see with the help of the software, what he mentioned just now, we will get a score from the patient, between patient and donor, and how good the bad score is, we will find out the prognosis. If score is good, yes, prognosis, we believe the transplant prognosis will be good. If score is bad, we believe the transplant might be not so well. So this is one information. And second is, with the help of epitope matching, we will clearly define our antibodies, and we, like Dr. Praveen was just mentioning about, if we have a donor who has having some antibody which is epitope is shared by some other allele. So this information of epitope sharing we will get from this epitope analysis. These are the two applications which we have in our setting in our transplant program till now. Coming to the little bit about the transplant program in Karnataka, what we do, our cadaver transplant program is quite good, we believe. It's almost 170 or 180 transplant cadaver donations we have, and all the patients go for, at the time of transplant, go for CDC, but the patient who are highly sensitized, we recommend to do a single antigen test and keep this information with us. The moment we have a donor available, I mean the cadaver donor available, we do low resolution HLA typing and do a virtual cross match, and on the basis of this virtual cross match information, hospital will decide, or the center will decide, whether to go ahead with the transplant or not to go ahead with the transplant. After doing low resolution HLA typing, next week the high resolution HLA typing is done of the same cadaver donor, and this information is kept for any further use. And of course, we believe this information will be used for transplant monitoring as and when it is required. So coming to the summary, I exactly finish in 20 minutes. So we believe there are so many tests which we do, but not like I mentioned earlier, this not all the tests we can or we should do for all the patients. We develop an algorithm of the testing which is suitable for our lab, and one cross-match assay should be supplemented by antibody assay. It could be single antigen, it could be PRA, or it could be a screen or anything. But it's good to have a cross-match and antibody detection assay in combination. And since the technology is available of high-resolution testing available almost everywhere, we should go for high-resolution HLA typing. It's a simple and cheaper also. So which will definitely help in virtual cross-match, and finally the donor selection and the good transplant outcome. This information is going to help. With this, thank you so much.
Thank you, sir. That was a wonderful talk. In such a short time, you told us many things. It was a really bird's eye view of different methods used in transplant immunology. Initially, you told us the different methods of cross-matching, then the different methods of antibody testing, and then the HLA typing, the low resolution, high resolution, and then the non-HLA antibody testing. Just one question from my side regarding the initial part of our discussion. If we have a more sensitive method like a flow cross match, can we skip a CDC cross match? I know CDC cross match is a functional testing, but if both are available, you told us the reason, but
yes.
Can we?
Yes, it has. I will give you both the answer, yes or no. Yes is yes. We have a study published from Delhi approach, which clearly says we can do away with CDC cross-match, we can skip CDC cross-match and go directly with the flow cross-match and virtual cross-match and so on. And not only this approach suggests this, many centers across the world has stopped doing CDC cross-match and depends only on flow cross-match. Only at disadvantage will be in your donor selection. Directly you will not be able to say no to exactly to a donor. You mean say CDC cross match gives me an answer of transplant yes or no with this particular donor. So this yes, or if you skip this, you will directly going to a flow cross match where you will approach will be only to deal with this donor. This is the only disadvantage which I see. Otherwise answer is yes, we can definitely stop CDC cross match, and Dr. Anil sir always say, oh, okay, this is a good time, we should say goodbye to CDC cross match and RIP to CDC cross match. Thank you. That's what, yes, okay.
Hi, that was a good talk. In cadaver wait list, do you repeat the DSAs? How long you give the validity of a DSA in your program?
Okay, so in Karnataka, we recommend SAB for all the patients who are highly sensitized, and the sensitivity is defined by the nephrologist who are treating the patient. We recommend once in a 6 month, it should be done. Some places they want to repeat once in quarter, that's fine. But we recommend this SAB to be done when the patient is in the priority in the list. Say if you register in Karnataka, you will get organ only after 4 or 5 years. So your antibody status today is not going to help you. So even if I do single antigen, waste my patient's money, it's not going to help in the patient in the transplant. So we recommend whenever the patients are in the priority, and depends on the ABO, like group wise, some group are very, the list is longer, and some group list is shorter also. So according to your the priority, we believe that whenever you are in the priority, that time we recommend yes, single antigen to be done, so that in next few months your transplant will be done on the basis of virtual cross match.
Just a practical question, logistics. You said you're doing, for all the donors, deceased donors, you're doing a high resolution NGS. What's your turnaround time for that? Because you have to get the donor very fast.
So for disease donor, first we do low resolution HLA typing, A, B, DR and DQ, 4. And this is done in 4-5 hours. It's in parallel to the CDC cross match. So CDC, one person is doing CDC cross matches for 5-6 and another person is doing HLA typing. So in next 6 hours, both the information will be ready, and single antigen information is already available for this particular patient. So after 6 hours, we will have a CDC is negative and virtual cross match is positive or negative.
Yeah. So nice talk. Do you count the memory DSAs when you have more than one SAB in your stock?
You mean once more than?
More than one SAB. Some people we were doing SAB, yes, priority. So do you count the memory DSAs also?
Yes, yeah, we have to give this information when the previous SAB, one antibody was present, and now this SAB, this antibody is disappeared. First of all, we have to find out this disappeared because of some kit related problem. This allele is not represented for some reason in the kit. We need to find out. And what we see, the antibodies which are with the low MFI value, these antibodies will keep on coming, going. But is very difficult to interpret it. High MFI value, how come suddenly this MFI is disappeared? Either the nephrologist has done some plasmapheresis or desensitization, which I have to know what is the reason. So of course we need to consider that the historical antibody information in today's SAB report.
A question again about that virtual cross match, because it's very interesting. We don't do in Kerala, we have very few transplants, disease donations, honestly. If the CDC is negative and your virtual cross match comes positive, what is the next step?
So this offer will go to the hospital. suppose say this, what CDC is negative. CDC is negative, information will go to Karnataka SOTO. Then all the CDC negative information, with the help of the priority, they will give the offer. Now virtual cross match will, on the basis of virtual cross match, some hospital will decide, okay, this MFI value looks 10,000, I don't want to go ahead with this transplant. Though CDC is negative, I don't accept this offer. Fine. Some hospital will say, okay, CDC is negative, MFI value of this antibody is 6,000, I will do some plasmapheresis now in next couple of hours and go ahead with the transplant. So offer will go from SOTO to the hospital, and when the center will decide whether to accept this offer or not.
Probably the last question.
Thank you for that excellent talk. My question is the lysate assay which you portrayed, based otherwise marketed very smartly as the DSA, is still being done in many places. So it's been, I think the articles have already come that there's a lot of false positive for this lysate assay which is being done, and actually should not be done, is what I understand from the latest article. So do you still do it, and what is, because we get a lot of false positive and then we are in a fix because it is used as a screening test many centers. So what is your opinion on that?
Okay, so two answers of your question. One is, yes, we do in our lab. A second also, yes, we do false positive. We do get false positive from a lysate cross match. So both the ways, yes, we do, but we know this is giving a lot of false positive information. But still, it's not so bad. Yes, say if you do, unfortunately, there is no data, no big information literature available whether this is relevant or not. Like we have to do, for any validation studies, you have to validate this test. How will you validate this test? Validate on the basis of some gold standard. If we say gold standard, single antigen and virtual cross match, so we have to validate backwards. Unfortunately, there is no as such study available which say, okay, I have done 1,000 single antigen virtual cross match, and parallelly I have done 1,000 DSA cross match, and the graft survival also we have to see. Unfortunately, there is no study available. We all are sharing our experiences. So from our experience, I say yes, this is false positive, but knowing that this is false positive still is a reasonable good screening test for the transplant.
Thank you, sir, for that truly inspiring talk. I request Dr.